Okay, doctors, we're going to move on to our next lecture, which is Coagulation and Hemostasis. This lecture is given by Dr. Michael Wu, who is assistant professor in the Department of Anesthesiology and Critical Care at the University of Chicago. Please welcome Dr. Wu.
Hello, thank you all for staying. Ironically, I'm here to not put anyone to sleep. Let's see. I am pressing. There we go. Okay, I have no disclosures to make, but I'm here all afternoon, so feel free to make me an offer. We have a lot to cover that is somewhat related. Let's just jump into it. Okay, this is how they're all related. This is that thing that you remember, you study for like 2 hours, you remember it for about 2 seconds. But that's okay because we're going to do it a bunch again. For the purposes of the next, say, hour or so, things that are red are things that make you bleed. Things that are yellow are things that make you clot or bleed less. It's like, giving FFP. That's why we did that. This green lightning is something that inactivates. Remember that some things that we're going to talk about actually do both. So we'll do this little exercise. Let's talk about a couple of endogenous anticoagulants, for instance, protein C and protein S. Protein C and protein S are endogenous anticoagulants, which is why they are red. They act here at factor 8, factor 5. Antithrombin is also a natural anticoagulant. These are things that you normally have. And they are red because they, in theory, if they were hyperactive, they can make you bleed. They inactivate at this level. Antithrombin inactivates thrombin. Hopefully that's intuitive. The thrombin is factor 2. Maybe you're thinking back to medical school. You remember a time when you heard about something called antithrombin 3. Well, antithrombin 3 is no more. Antithrombin 3 is now known as antithrombin because evidently antithrombin 1, antithrombin 2 are not clinically relevant. But the terms are used interchangeably. Some of you may remember activated protein C, formerly called Zygra, which is now black boxed by the FDA. It was an anti-sepsis drug. And if you remember, one of the reasons why it was taken off, besides all the politicking that went to its actual approval, the reason why it came off or was FDA black boxed, because there were so many reports of bleeding, okay? And this should fit into our model. Why? Because it's activated protein C, and if you have hyperactive protein C, it should make you bleed. That's why all these things are red. Some of you also know that patients who have, for instance, a protein C deficiency is a hypercoagulable state. This was originally yellow letters on a blue background, but so this is supposed to be yellow, because a protein C deficiency is you're missing an endogenous anticoagulant, so you are hypercoagulable. That will make you clot. So protein C deficiency, this should be yellow lettering. Let's jump into warfarin. Question. Polling is open. An 80-year-old man with a history of AFib, hypertension, and coronary disease is scheduled for cataract surgery. He is on warfarin with a target INR of 2 to 3. How should this patient be managed perioperatively? Option A, stop warfarin 5 days before surgery, that is, hold for 4 doses. B, use unfractionated heparin, or UFH, or low molecular weight heparin as a bridge therapy. C, no reason to discontinue warfarin therapy. Or D, use 2.5 milligrams vitamin K intravenously to bring down the INR. Or E, use 10 milligrams of vitamin K sub-Q or 2.5 milligrams vitamin K orally. Do I click for the 5 seconds? I'll give you 5 seconds. Okay, great. Now, obviously everyone's concerned bleeding in the eye is bad, but cataract surgery is categorized as a low risk for bleeding procedure. So for cataract surgery, there's no need to discontinue warfarin perioperatively. And additionally, while AFib increases your annual stroke risk, right, it isn't, I guess, biochemically a hypercoagulable state, which is why bridging therapy is not necessary. Let's talk about, excuse me, warfarin. Warfarin inhibits is a vitamin K dependent factor inhibitor, factors 2, 7, 9, and 10. Remember that warfarin also works on proteins C, S, and Z. Anyone care to guess which one comes first? That's not a real question. Now, that means this. These red W's, which is the flying W because warfarin was invented at University of Wisconsin. Guess where I went to school. Anyway, so warfarin works at 2, 7, 9, and 10, and it inhibits these clotting factors, which is why it's red, which is why the W's are red, and it makes you bleed. But warfarin also inhibits your natural anticoagulants. So if you inhibit protein C and S here and here, it could make you clot. The inhibition of protein C and S are faster, so your initial experience, if you're taking warfarin, if you take it cold, is a hypercoagulable state, which is why you can get warfarin skin necrosis. So for people who are starting warfarin cold, bridging is generally recommended. Now you may ask yourself, I never do this, and I never see this, or maybe you've seen it very, very infrequently. I do think that starting warfarin on inpatients is different than starting warfarin on outpatients. People do part of the stress response, so on and so forth, that I think you don't have this issue, and your proteins C and S are probably otherwise occupied. Are you hearing me okay? Am I blowing you out? This is actually on my throat, but it's okay. Okay, so know that you can be hypercoagulable when you start warfarin cold because the inhibition of protein C and S happen first. This is from, Archives of Internal Medicine, but this has been repeated elsewhere. Most patients can undergo dental procedures, arthrocentesis, cataracts, and diagnostic endoscopy, not procedural endoscopy, without alteration of warfarin regimen. Heparin. Question: which of the following patients on warfarin should receive bridging before surgery? A, venous thromboembolism event greater than 6 months ago. B, carotid atherosclerosis without recurrent strokes or TIAs. C, patients with thromboembolic event and a deficiency of protein C, S, or, lo and behold, antithrombin 3. D, AFib without multiple risks for cardiac embolism. Or E, newer model prosthetic valves in the aortic position. Good. So the systemic, I would call it biochemical hypercoagulable state, which is a protein C/S deficiency or antithrombin 3 deficiency, are people who they're good at clotting. They're good at clotting when nothing's happening. These people should be bridged. This is the newer model prosthetic valve. Excuse me, is a terminology you'll see on the exams. Essentially, newer model is any model that's not a ball in cage. Okay, and I mean, from what I hear, people who had these ball and cage aortic valves, you knew they had a aortic valve replaced because you walk on the rim, you could hear the clicking, right? These things haven't been used in 20 years, more than 20 years. Easily more than 20 years. So tilted disc or any of the valves that they're using these days or anything that I've seen in the last at least 15, definitely 20 years qualifies as newer model. Okay. I hear they were really really well made. Like you could literally just kind of brush it off and put it to the next person, it will work just fine. But they're incredibly embologenic. Anyway, so this is from a statement article in Chest about low, moderate, and high risk for perioperative arterial or venous thromboembolism. We're going to break this down, and indications for VKA is vitamin K antagonist therapy. Okay, so essentially a low-risk person you can do sub-Q heparin, SCDs, or whatever. High risk, you're going to bridge. Moderate risk is where you use your judgment. Let's see, for mechanical heart valves, the high risk is these ball and caged, or the old original tilting discs. Again, these things haven't been used in a very, very long time. Anyone who's had a CVA or TIA in the last 6 months. These are essentially modern valves, people who also don't have arrhythmias. Here's where everyone else, you use your judgment. Okay, a modern aortic valve, prior history of TIAs or strokes. I had a TIA, fully recovered. It was, exactly 6 months ago. Versus, and you're doing, I don't know, open AAA or something like that. So maybe that's someone you don't want to bridge. Note that the magic cutoff for age is 75. Okay, it seems as longer I am, the higher that goes. That's okay. For venous thromboembolic events, when I was growing up, the magic number here was 6 months. It was greater than 6 months, less than 6 months was a cutoff. But now it's going to events within 3 to 12 months. Okay, so definitely you're going to bridge people who've had a DVT 3 months ago. Okay, within 3 to 12 months. Then you can use your judgment, and if the event was greater than 12 months ago, then you definitely can go to your routine VTE prophylaxis. Note that protein C, protein S deficiency, antithrombin or antithrombin 3 deficiencies, antiphospholipid. These are the major hypercoagulable states that require bridging. There are minor bleeding states that are factor V Leiden is probably the most common that don't really dictate a need for perioperative bridging. AFib, here's where you're going into your CHAD scores, okay? And here is the CHADS VASC scores. There's A1, which is age over 65, A2, which is age over 75, where you get 1 or 2 points. S1 is actually gender and female gender, so technically S1 is she. S2 is stroke or TIA. These are the point scores, and they all go to annual stroke risk, right? And the cutoffs here are 0 to 5% for low, right? And 5 to 10% for moderate, and then greater than 10% for high. Okay, so greater than 10% increased annual stroke risk, these people are getting bridged. Less than 5% annual stroke risk and higher annual stroke risk is you can do routine prophylaxis, and here's 5 to 10% is where you use judgment. Okay, I'm just going to breeze through this because I think you guys get it. You look pretty smart. Okay, so let's remember how heparin works. Heparin binds, it's a facilitating drug. It binds antithrombin, formerly known as antithrombin 3, to inhibit thrombin. So it helps antithrombin do its work. It also works at factors 9, 11, and 12. Remember that heparin binds to platelets, which can either induce or inhibit platelet aggregation. Generally speaking, it'll prolong your bleeding time. If you think bleeding time is relevant, most people don't. This osteoporosis issue is hardly clinically relevant, but great testable material. Right? Meaning the complications of heparin, and they don't have anything about bleeding in there, but they do have something about osteoporosis. That's where they get you. Okay, so to review, the heparin antithrombin complex works at all these levels. bless you, low molecular weight heparin works primarily at factor 12. Okay, so let's put that back into our regular tree. Antithrombin here, it inhibits factor 2, which is thrombin. Okay, and heparin plus antithrombin amplifies the inhibition of thrombin. So if you inhibit a factor, it bleeds, which is why this stuff is red. Low molecular weight heparin does have activity here, but has more of its activity up here at factor 12. Again, since it inhibits here, it helps you bleed, which is why it's red. I'm going to go back one slide. Antithrombin itself is a serine protease inhibitor. Those are words we're going to remember for later, mostly because serine protease inhibitors are a family of, I'm not going to say drugs, but say molecules, okay? That's going to come back later. Protamine is also in that family, which carries irony, such as we're going to irony right now. Okay, so remember that protamine is a fish sperm derivative that binds heparin. Okay? And I do think the fish in question is salmon, but don't quote me on that. Anyways, remember that protamine has been associated with an anaphylactoid reaction. Okay? Let's see. People who are at risk for anaphylactoid reactions with protamine include diabetics who are on NPH, because the P in NPH stands for protamine, men who have had vasectomies, and people with fish allergies. The fish allergy and the previous exposure should be intuitive. And as far as people who've had vasectomies, evidently, if there's anything that men and fish share besides a desire to get away from it all, is an antigen on your sperm. So if you've had the vasectomy, you've exposed yourself to your own sperm that has the same antigen or similar antigen to protamine, so you're at risk for anaphylactoid reaction. Let's see. The protamine will neutralize the antithrombin and heparin activity, and it can normalize your PT-PTT. In animal models, there are some microvascular effects. We'll go into that. So let's see, heparin and antithrombin 3, it's red because it makes you bleed, because it inhibits all this stuff, but protamine will reverse the heparin, will bind the heparin, kind of chelate the heparin. It has, if you're using enoxaparin, or if you're losing low molecular weight for therapeutic anticoagulation, protamine is great at reversing that, although the primary use of protamine is reversal of anticoagulation for coming off of cardiopulmonary bypass. So, okay, good. So back to our regular tree. Protamine is yellow. Why? Because it helps you clot, or at least it helps you bleed less. Why would you be bleeding? Because you gave someone high-dose low molecular heparin or therapeutic levels of heparin. Okay? Now, this is where the fun begins, because protamine and antithrombin, they're both serine protease inhibitors. They're in that molecular family. Okay? And so the funny thing about protamine is if you give it, so it works by encapsulating the heparin and disallowing its ability to facilitate. If you give protamine in isolation, because it's in the same family molecularly as antithrombin, it can work as an anticoagulant. So if you give protamine without heparin, it can make you bleed, which is why protamine should actually be, as it is here, half yellow, half red. It depends on what you gave previously or what you didn't give previously. The classic ICU conundrum is someone who's just had on-pump cabbage. They're coming back from the OR, and they're kind of oozy, and they're kind of bleeding. And one person will say, well, it's because someone didn't give enough protamine. And then another person says, well, maybe it's because you gave too much. And in both situations, you'll be bleeding. So the big question is, how can you assess that? And the answer is you give more FFP, which is not a test answer, but what a lot of people do in real life. Okay. Let's talk about platelets, or the lack thereof. Question: which of the following is the most appropriate step in the management of heparin-induced thrombocytopenia, or HIT, a potentially catastrophic generalized thrombotic disorder triggered by heparin therapy in a patient who has recently undergone coronary artery bypass grafting and mitral valve replacement? A, discontinuation of unfractionated heparin. B, discontinuation of unfractionated heparin plus treatment with a direct thrombin inhibitor. C, placement of an inferior vena cava filter. D, administration of low molecular weight heparin, otherwise known as LMWH. E, institution of immediate fibrinolytic therapy. Polling is open, and 5 seconds. Good. Excellent. Now, those of you who went for answer A, I like you people, because DTIs frustrate me, because every time I use them, well, less nowadays, but because they bleed. They always bleed. People on argatroban, Leparoud, and so on and so forth, they bleed, and you don't have a reversal agent, and you're just stuck transfusing. But transfusing people when they're bleeding is better than praying for them because they've had a catastrophic clot somewhere. So, yes, the answer is stop the heparin and give them a DTI. Okay? One of the concepts here is that low molecular weight heparin is still heparin, and the problem is heparin. So stop the heparin. Great. So, HIT, or heparin-induced thrombocytopenia, has undergone a number of nomenclature changes over the last, say, 15 years, depending on when you grew up. There used to be HIT and then HAT, and then there was HIT, and then there was a HIT 1 and HIT 2. The idea, then they all kind of fell into this category. One is that sometimes when you give heparin, that the heparin coats the platelets, which marks them for destruction by a reticular endothelial system, which could create thrombocytopenia. The second T in HIT is heparin-induced thrombocytopenia and thrombosis, which is you get these heparin platelet factor 4 complexes, which both cause a drop in your platelet count, and then you develop clots. And they frequently are arterial more than they are venous, but they can be both, and they can be dramatic. So the risk factors for this, note that the thrombocytopenia and thrombosis is associated with a greater than 50% drop in your platelets, so it's a relative number, not an absolute. So just because your platelet count drops below 100 doesn't mean you're in. If you go from 300 to 100, guess what? You're in. Re-exposure within a little over 3 months. The time course of the thrombocytopenia is about a week in. So if the patient comes in, platelet count 250, and post-op day 1 or hospital day 1, their platelet count is 50. It's probably not the heparin, unless they were transferred from another hospital, which they got heparin, and it just came to you. And severe thrombocytopenia is usually not HIT. Okay, so the platelet count is less than 60,000. The platelet counts of like 10,000 or so on and so forth. It's usually not HIT, usually something else. Then you always have to ask yourself, well, what if there's multiple issues going on? Well, if it was easy, they'd let monkeys do it. Anyway, so this is the 4T test, okay, for HIT, or estimating the risk I'm sorry, not the risk, but the likelihood that the patient is having HIT. And you get 0, 1, or 2 points. And the T's, okay, T is thrombocytopenia, so severity. Timing, this T is thrombosis. If you have venous, definitely if you have arterial thrombosis, that patient is very, very likely to have HIT. Note that the fourth T is the T that's in the word other. It's not really a T, but it makes the test sound nice. Meaning if you have another reason for the patient to have thrombocytopenia, if they have, myeloproliferative disorder or something like that, then well, then it gives you a point score. Using that point score, the pre-test probability, then you can combine it with tests. There are a number of tests available out there. One of them is the PF4. Okay, it's a simple antigen assay. Okay, and then there's a confirmatory test. It's the I'm blanking. It's a serotonin release assay. It's a serotonin release assay, which is only done in a few areas. So, for instance, if you need to do the SRA in the Chicagoland area, we actually have to send it to Minnesota. So it depends on how badly it's snowing, on whether you get it back soon enough. Anyway, so the PF4 assay, antigen assay, is more of a screener, and that combined with clinical probability scores, then it's a matter of whether you need to do the confirmatory test. Okay, there used to be a whole old heparin-induced platelet aggregation test. That's too many false positives and false negatives, so it's not recommended anymore. Now, let's say you have your patient, they've got the hit, but they're doing okay, and you're aiming them for discharge, and you don't want to put them on antithrombin inhibitor or infusion. Actually, we have many more options these days, but let's say you want to put them on warfarin. The general recommendation is that warfarin should be delayed until the platelets recover. Okay, so until the platelets are on an upswing, at least over 60,000, I think people tend to feel better. If they're over 100,000, because there has been a non-trivial incidence of limb gangrene with cold starts of warfarin on people who have HIT. Remember that HIT is it's a hypercoagulable state. The DTIs, these are the IV DTIs that we have. PO, there's what's Pradaxa is dabigatran, and that's available PO. So dabigatran and argatroban has the shortest, it has not the shortest half-life, but it has liver elimination, whereas leparudin, bivalrudin are leech venom derivatives, and they undergo renal elimination. Okay. The other thing to note is that with argatroban, you get a false elevation in your PT and INR, consequently. So your INR can read 6, 7, but your coagulation state may actually be normal. And so one question is, well, how do you transition to warfarin if you're on argatroban? And the answer is you start your warfarin, you wait a couple days, you turn off your argatroban, and then see where the INR settles out. And if you're therapeutic, then great. And if you're not therapeutic, you run back to argatroban really fast. That's the limits of current clinical experience. Although I think the modern anticoagulants I think give you a little bit better leeway. Okay, so in contrast to heparin, DTIs, or direct thrombin inhibitors, work on thrombin directly. So they don't need, heparin needs to combine with antithrombin to do its work. Argatroban, leparudin, bivalrudin, and dabigatran, or Pradaxa, will work on thrombin directly. Okay? And I've had this question before. What about the other novel oral anticoagulants? We're talking about the rivaroxaban and apixaban and so on and so forth. And those are so much fun because they sound a lot like argatroban, but they actually work here. Okay, the Eliquis and I don't know the trade name of the other one. Anyways, but apixaban and rivaroxaban, they work. They're factor Xa inhibitors. Okay, so they don't, although they sound like dabigatran, they sound like argatroban, but they work over here. Let's talk a little bit more about bleeding. Which of the following is an acquired bleeding disorder? A, von Willebrand's, B, Christmas disease, C, Bernard-Soulier syndrome, D, idiopathic thrombocytopenic purpura, or E, protein S deficiency. Hard to acquire something with someone's name on it. Good. Excellent. Also, I think it has idiopathic in its name, which is presumably, I mean, you don't know how you got it, so it's not like you got it from your parents, right? So, good. ITP is acquired, protein S, that's a genetic, all these things are passed through the family. Let's see, ITP is an autoimmune phenomenon, okay? What happens is you develop IgG, which binds platelets and which marks them for destruction in the spleen. Causes include viral infections, collagen vascular diseases. This shouldn't be too much of a surprise because a lot of those collagen vascular diseases are autoimmune in nature anyways. Lymphoproliferative disorders, so surprised to make the wrong IgG. Drug-induced, and then of course toxins. These are linked to genes. I'm going to just skip this over. Okay. Von Willebrand's disease, okay, is a qualitative or quantitative deficiency in von Willebrand's factor. Okay, von Willebrand's factor, which is right here, is a carrier of factor 13. Okay, so it facilitates this reaction. And the disease either is a defect in the protein itself, okay, or it's a defect potentially in actually in the receptor or in just the quantity. Cryo has von Willebrand's factor in it. Cryo also has factor 8, has fibrinogen, factor 13. And even though it has VWF in it, it is the second-line treatment for VW disease. Second line, okay? It is also a second-line treatment for factor 8 deficiency. And these are all very intuitive because, well, if you don't have factor 8 and you don't have von Willebrand's factor, wouldn't cryo, which has both of those things, be the first-line treatment? And the answer is no. No, it is not, because you don't need a whole lot of these factors to be clinically relatively normal, okay? It means you won't bleed out of control, but you will bleed more than most. Okay, so remember, cryo has factor 8. Cryo has VWF. Cryo has fibrinogen, and it has factor 13. So multiple, it's a mix. It's a mix of clotting factors. Is cryo first-line treatment for anything? For instance, DIC? And the answer is hard to say, because DIC is so hard to treat anyways. Remember that DIC, right, that C stands for coagulation, disseminated intravascular coagulation. The primary problem is clotting. It is clinically discovered with bleeding, right? Because primarily it's a consumptive coagulopathy, right? So you figure that the patient's in DIC because they're bleeding, but what you have to realize that before that they clotted because of stress, cytokines, because of, well, coagulation because of, let's say, they've been bleeding everywhere. And also because you have a decrease of endogenous anticoagulants, okay? So what happens? You coagulate so much, right? You lose your natural anticoagulants, also because of plasminogen activating inhibitor type 1. And because of consumption of all the clotting factors, and because this happens so much, you end up bleeding. And that's when you figure out that you're in DIC. So, from the International Society of Thrombosis and Hemostasis, the diagnosis includes these labs, but the treatment is not to treat the labs. The treatment is to treat bleeding, okay? And whether that's thrombocytopenia, or if you can figure what specific deficiency you have, whether you can do that with routine coagulation studies, or point-of-care tests. TEG is very popular, although I think it has mixed reviews in the literature. Then you treat the patient, right? You treat the patient. If they're bleeding, you give them what they need. If they're not bleeding, theoretically, you don't have to give them anything. Because if you give them cryo, right, cryo doesn't have platelets, but maybe the issue is that they're thrombocytopenic. So now you're just treating numbers, which doesn't necessarily help. The fibrinogen, treating fibrinogen alone is insufficient as far as the diagnosis of DIC because fibrinogen varies in relationship to stress and should really only be given in deficiency and in the presence of split products. Other options that have been employed in history are mostly under mixed review because a few people use it with success, they publish it, and nobody else finds the same success. This includes prothrombin complex concentrates. There are 2 types in the U.S. One of them lacks factor V, the other one doesn't. There was the logic that if the problem in DIC is clotting, maybe we should give heparin, and then we could prevent DIC. And then they used it, and the patient didn't die, but they still bled a lot. So it logically made sense. Clinically, it wasn't clear. There's some stuff that's great in the lab. Activated protein C, you couldn't do it unless you want the federal government after you. Tranexamic acid, I think is interesting, but the issue here is it's an antifibrinolytic, so the labs need to characterize high split products, low fibrinogen. Then I think tranexamic acid has its role if the patient's bleeding. VTE. Okay, in cancer patients, high risk, those under 60 years of age without additional risk factors and undergoing surgery, which of the following regimens represents the VTE prophylaxis of choice? A, intermittent pneumatic compression, IPC, sleeves, plus gradient elastic stockings, plus unfractionated heparin, 5,000 units, 2 hours pre-op, then every 8 hours. Enoxaparin, 40 milligrams, or dalteparin, 5,000 international units daily. B, warfarin. C, extended prophylaxis in selected high-risk patients. Post-discharge, 40 milligrams of enoxaparin daily for a month. D, enoxaparin, 40 milligrams daily. E, dalteparin, 5,000 international units daily. Polling is open. 5 seconds. For anyone who's ever done any computer-based training for, certification of this or that for your hospital, this is one of those questions. The longest answer is always right? Let's see. This is not to say that these answers are not relevant. Okay, for the highest risk of patients, especially cancer patients, yeah, you're going to send them home with enoxaparin for a month. Okay, but the question was about prophylaxis, and this is tough because this is one of those questions we have to go with implication. The implication was, perioperative also. Okay, and arguably the answer is A plus C, right? But A is the best answer here. So. Conceptually, I would agree with A plus C, not C alone. And then D alone is not enough because stockings also help and they're cheap. The risk factors for venous thromboembolism are vast. I'm not going to go into all of them, but they're all basically relevant. Acute medical illness, big surprise there. Smoking, obesity. This I put in mostly for your handouts because it's too small to read on a slide. But note also that there's low risk, moderate risk, high risk, and then highest risk, which I think is a strange way to characterize it, but I didn't write the chart, so that's okay. All right, we cut up the risk a little bit, and here's where, low risk, you just walk them, right? That's the treatment. If they're moderate risk, then you're going low dose unfractionated heparin or low molecular weight heparin. GCS is graded compression stockings. right? Or IPC is intermittent pneumatic compression, right? In our hospital, that they used to be called SCDs, and now the machine changed. They call them ALPs, but we still call them SCDs anyways. High risk, you're going with higher dose, lower frequency of the same dose of heparin. And then you're definitely, instead of doing just TED hose, which is graded compression, you're doing intermittent pneumatics. So this is definitely the SCDs. The highest risk is potentially warfarin, or intermittent pneumatic compression plus low-dose heparin. Okay, and that's hips, right? People come in, they take their warfarin on day 1 or day 0 or day -1, and then come in and have surgery. Okay, this is also from CHEST. In selected high-risk general surgery patients, major cancer, we suggest post-hospital discharge. So that's in there. I think it's generally recommended. I don't think it's made it to a standard at this point. We might recommend against the use of aspirin for prophylaxis of VTEs. I just think this is interesting because they in their position paper, they're saying don't use aspirin because they know that people out there are using aspirin just to throw something at someone who, they've had so many bleeding risks that they can't throw heparin or whatever on them, and so they use aspirin instead. That's you're treating the physician, right? You're treating yourself. You're not treating the patient. All right, let's talk about transfusing people. Transfusion of packed red blood cells are not indicated in which of the following scenarios are not indicated? A, the asymptomatic 69-year-old with a hemoglobin of 6.9. B, the 27-year-old trauma with bleeding and hypotension and blah, blah. C, 72-year-old with chest pain, shortness of breath with a hemoglobin of 9. D, 90-year-old post-op right hemi with a hemoglobin of 8. E, 44 femur fracture with tachycardia orthostasis, hemoglobin of 7. Polling is open. Use your 5 seconds. Okay, good. Good spread. Now, we'll get to this, the hemoglobin of 6.9, because that certainly raises anyone's eyebrows when you're less than 7. C has been controversial for the last at least 10 years. Of like, what is the magic hemoglobin for someone with coronary disease? Let's say someone has cardiac disease and they're perioperative. They're coming in with a hemoglobin of 8, 9. Those of us, I know I grew up in an era where you have coronary disease, you're going to push them to 10 because they do better. And in animal studies, even 11 was even better than 10. And the data here is pushing that number lower. The most recent ACCHA guideline, I think 2016, said that 8 is probably okay, that there's not a whole lot of data that really is pushing 10. This is different because the implication of chest pain, shortness of breath is that the patient's having acute coronary syndrome. And in those situations, that is an indication for transfusion. I'm not saying it's the right thing to do, but it is an indication for transfusion. Whereas, remember, the 8 is probably okay. And 90, while old, is just a number. Okay, red cell transfusion. This is from the textbook. This is from Cecil's, right? Asymptomatic patients without risk factors can tolerate hemoglobins down to 6, right? This is from the textbook, down to 6, okay? In this medicine textbook, they also say surgical patients with no risk factors, their number is 8. The data here that they reference is not so great, or at least kind of vague at the very least. And Cecil is also saying 10 for coronary disease at risk for myocardial ischemia. Although the risk factors, I don't think they're talking about major, minor coronary risk factors. I think they're basically saying if they're having ischemia. At least that should be the modern interpretation. The consensus statement from JAMA, I don't always agree with everything JAMA says, but this one I like, because the first overriding statement here is physician judgment, which is probably the best thing, or at least the most defensible one. No single measure can replace good clinical judgment. Experience suggests that acute anemia of less than 7 frequently will require blood transfusions. Okay, so I do think that the magic number in healthy people is 7. Most of that experience comes from Jehovah's Witnesses who have survived, down to hemoglobins of 5. In extremely rare cases and younger, maybe less than that. Let's talk about massive transfusions. Massive transfusions has also been a somewhat area of controversy if there's any kind of advantage of being at war for the last, 16 years or so. Massive transfusion used to be defined as a blood volume within a day, which is hard for anyone who does trauma because, if you bleed out within an hour, do you have to wait the 24 hours to qualify for massive transfusion? And, the bean counters will say yes. So there's always a dynamic massive transfusion, which is, more than 4 units in an hour. The trend, I would say maybe it's continuing, is 1-to-1. Okay, meaning giving a blood to FFP 1-to-1 seems this has been, one of the more quoted studies, but that the decrease in mortality of 1-to-1. This is not necessarily a controlled study. There are other factors, and these are younger patients. But those I was at a lecture with the former chair at UCSF, and he was quoting the days when they would just drain from one soldier, put it in the next, and that they did so great, and whole blood was so good, and isn't it funny we're coming back to whole blood? We're not really coming back to whole blood, but it does seem that 1-to-1 is better, and certainly going towards it. The lysine analogs. This is, like when I wrote this, there was a play that was big in the Chicago area called the Vagina Monologues. I don't know if anybody know? Okay, anyway, so it was funny back then. Anyway, so which of the following should be the antifibrinolytic of choice in major surgery in children or adults, given its ability to reduce blood loss and transfusion of blood products after cardiac surgery without any serious adverse effects? A, protein, B, aminocaproic acid, C, tranexamic acid, D, combination of aprotein and amicar. Amicar is aminocaproic acid. E, combination of aprotein, amicar, and tranexamic acid. Polling is open in 5 seconds. What a spread. So, a couple of things. One is that aprotein was black boxed by the FDA 15 years ago, I want to say. Although there have been rumors of its revival, so we're going to put it we put it in the combination of zombie drugs that'll never die. Aminocaproic acid, or epsilon aminocaproic acid, is an antifibrinolytic that has been shown to decrease bleeding but not decrease transfusion, last I checked. Tranexamic acid has a better record. So let's see. All these drugs work in this area. So there's this plasminogen gets converted to plasmin. It's an endogenous anticoagulant. And it inactivates the fibrin clot. Okay? So it helps you, it makes you bleed. So if you give it a fibrinolytic, these should be yellow. A tranexamic acid or epsilon aminocaproic acid. These two work here. This one works here. It inhibits these, and so they don't really make you clot as much as they make you bleed less. Okay, which is why these guys should be yellow. Aprotein also has some work at the kallikrein system, so works here too. Oh, I'm sorry, that should be green. Now, tranexamic acid and aminocaproic acid, they're antifibrinolytics, okay? And in a meta-analysis, now remember, there's a lot of people who say a meta-analysis is not an analysis. But that tranexamic acid and a protein reduce transfusions after cardiac surgery on bypass, unlike Amicar. Okay? So Amicar can reduce bleeding depending on what window you're looking at it in the perioperative situation, but doesn't necessarily reduce your transfusions. Tranexamic acid and a protein reduce bleeding and they reduce transfusions. Tranexamic acid has been studied in all these things, and it seems to reduce either bleeding or bleeding and transfusion. So that includes vaginal bleeding, upper GI bleeding, liver transplant bleeding, TERP bleeding, ophthalmologic, even dental patients who are anticoagulant for whatever reason. Let me go back for a second. Note that a protein or Amicar or a protein has also been studied in many of these realms with superior results, right? Even less bleeding, even less transfusions, but even more mortality and more renal failure. As well as MI, which is tragic because usually you got a protein because you're getting their coronaries bypassed, and strokes and so on. And that was mostly due to this article. It was written by this guy. I didn't want to show his whole name, but one of the controversies that one of the people associated with this study had a contract with Bayer and then lost the contract with Bayer in order to do some of his other research, and so he decided to assassinate this drug. That doesn't necessarily mean that the research was wrong. We all knew that a protein had higher risk, but we also were tended to use it on higher risk patients, but it still seemed to elevate the risk higher than expected, or at least statistically proven. But it's been at least 10 years since this, and I think people are either just forgetting or they're revisiting the data or study methods, and there's been back-channel rumors that a protein might come back someday. Well, we've gone to inhibiting vitamin K so much. Let's talk about vitamin K. 75-year-old woman with a history of AFib, hypertension, coronary disease, made it to the hospital, scheduled for orthopedic surgery for a hip fracture in 20 hours. Stress test in the past year was negative. Her INR is 5.5 on admission. How would you decrease the INR to less than 1.5 so that the surgeon can operate on this patient in 20 hours? A, FFP. B, vitamin K sub-Q. C, vitamin K oral. D, vitamin K IV. E, combination of FFP and IV vitamin K. 5 seconds. Okay. This is the one that's so much fun. The idea here is two things. One is that FFP isn't particularly good at reversing warfarin, generally speaking. We all do it. Usually bad things don't happen. But whenever it's been studied, it's just not good at reversing warfarin, except at very liberal volumes. Sub-Q vitamin K, it's hard to describe a role. Oral and IV, the issue is time. Okay, so in this study, FFP versus clotting factor concentrates. Now, this was a mix of either PCCs or even Novo-7. And with FFP, you can get a person down, I think it was greater than 5, down to 2. And then with PCCs, you can get them down to 1.3. Right? This is a different assay for warfarin efficacy. So their conclusion was clotting factor concentrates are the only effective action. Where's the... Sorry. So if I remember correctly, the volume necessary here was like 2.4 liters of FFP, right? So there's issues in there too. Okay, so how to reverse warfarin, especially if there's associated intracerebral. So this is people who have bleeding CVAs, right? If you stop warfarin, normalized in 5 to 14 days, vitamin K can give you reversal within 6 to 24 hours. 6 hours is the absolute fastest if you give it IV. If you give it PO, it's going to take a day. Okay? FFP, oh yeah, here. The volume is 2 to 4 liters to normalize an INR. So it carries those issues. But you can get reversal within 3 hours. PCCs, the one that we use at our hospital is called K-Centra, or prothrombin complex concentrates, can give you reversal within 15-10 minutes. Factor 7A, or activated factor 7, Novo-7, can give you 15 minutes. Okay. This study it came out just on the verge of widespread American use of PCCs. PCCs had big fanfare associated with them because factor 7 has already had many reports of hypercoagulability and arterial thromboses and so on. And PCCs land in the U.S. and seem to do okay, but I think the reports are beginning to accumulate of morbidity associated to hypercoagulability or arterial thromboses. And then there's a whole thing about, there's 2 types of PCCs that are commercially available right now. Vitamin K is also known as phytonadione. Anaphylaxis has been its reputation. The reputation is well-deserved, but the incidence has been decreasing. And it may be because of the formulation of the vitamin K. It might be the carrier. Evidently, castor oil used to be part of the formulation. It's not anymore. Oral onset is minimum 24 hours. So actually, I'm going to go back to the question just for a second, if I can. And the issue here, the issue in the question, right, why is it IV versus oral? And the answer is surgery has to be done in less than 24 hours, right? So if the surgery can happen tomorrow, then your options might include oral vitamin K. But because it's 20 and not 24 hours, and because the orthopod needs to do something 4 hours later, that the answer becomes IV vitamin K. Now, this is a kind of an alteration of the original chart, which can be found here. But let's see. Here, what you have is a patient who's not bleeding, a patient who is either having a high risk of bleeding or urgent surgery, or someone who is bleeding. Okay? And we're going to go across this way. And what should you do if their INR is more than therapeutic but less than 5? That's this column. Here is more than 5, 5 to 9, or greater than 9. All right? And as you can see, once you're bleeding, it's everything including the kitchen sink, right? Obviously, you're going to stop the warfarin. IV vitamin K, FFP, PCCs, or Novo-7, you're going to use your judgment there. All right? If you're not bleeding and your INR is less than 5, okay, you admit them, you adjust the dose, and that's it. If their INR is greater than 5 but less than 9, you're going to adjust the dose and draw coags. If they're greater than 9, you're just going to say the risk of bleeding is too high. So hold the warfarin, you're going to draw coags, and you're going to give them oral vitamin K. Okay? Now, if you're having urgent surgery greater than 24 hours, you're going to give the vitamin K to reverse of the 5 to 9 range. Okay? And then oral vitamin K should, and then oral vitamin K also occupies this spot. If you have urgent risk of surgery, then you can adjust the dose or monitor frequently, or actually you have the flexibility to start oral vitamin K too, but this is where it kind of it becomes mandatory, so to speak, or recommended by chest. All right. This may look like a mess, but it's going to make sense to all of you. Why? Here's the tree. We talked about what? We talked about the red W's that make you bleed. That's warfarin. They work at 2, 7, 9, and 10. But we also know that warfarin works on protein C and S, which is why there are yellow W's, because it make you hypercoagulable, because this stuff works first. We know about heparin. Heparin needs antithrombin, or facilitates antithrombin to inhibit thrombin. Okay? We also know that antithrombin used to be called antithrombin 3. And that protamine will reverse the heparin, which is why protamine here is yellow. Protamine also works on low molecular weight heparin. Low molecular weight heparin works to inhibit factor 12. Now, protamine given alone, working independently, because it's a serine protease inhibitor, also will work on heparin in and of itself, which is why protamine is also red as much as it is yellow. It depends if it's in the presence of heparin or not. Cryo will help you clot at these areas because it has fibrinogen in it. It has factor 13. It has von Willebrand's factor. It has factor 8. It is the first-line treatment for nothing, but second-line treatment for deficiencies in any of those things. Okay? DTIs, in contrast to heparin, argatropan, leparudin, bivalirudin, we can add dabigatran in here. Our direct thrombin inhibitors, they work on thrombin directly, doesn't need to facilitate antithrombin in order to make you bleed, right? Even though they sound like argatroban, apixaban, and rivaroxaban actually work here, which is also where fondaparinux works. They don't sound alike, but they work on the same factor, activated 10A. And then lastly, antifibrinolytics like tranexamic acid or epsilon aminocaproic acid are antifibrinolytics because they inhibit plasminogen, so they allow you to bleed less. A protonin, this should be yellow, inhibits here to do the same thing, but you can't use it. But get back to me in about 5 years. We'll see what happens. See? Easy. Hand in the back. Sure. So the question is the dosing of vitamin K 2.5 versus 5 versus 10. Is there? I'm not aware that there's better effect at higher doses. And to be perfectly honest, I'm pretty sure that's not going to be tested. But I am not aware of the relationship between 10 milligrams versus 2.5 milligrams of vitamin K. I do believe there's an absorption issue. Another hand. Great question. So is there a dose recommendation for the degree of iron? And the answer is no. Another hand here. If I recall correctly, you monitor 10A levels, but the main action's at 12.